Thank you, Richard, and good evening, everybody. Thank you so much for joining us. We're looking forward to a lively discussion this evening with Dr. Hall and Dr. Abadara, and I'll walk through an introduction of them in just a few moments, but really excited to be talking to you tonight about the Illumicite platform. We launched this product within this last year and have had just outstanding success, and so we're looking forward for the two of these gentlemen to bring us through some of their experiences. They have lots of slides and video and things to share with you with their experience, and looking forward to the questions and things that you may have of them as we go through the presentation. We want to make sure that at the end of the session, you'll have had the opportunity to find out kind of new strategies as to how to successfully biopsy with confidence with the Illumicite platform. Gain insights on the value of fluoroscopic navigation, which is a big part of the Illumicite procedure, and learn some additional benefits of the Illumicite platform. I think both of these gentlemen will be able to share how their practice perhaps has changed some with this new technology and how they're now taking a look at their patients and their business and addressing things that they may not have in the past. So I'll leave that up to them. Next slide here, just wanted to share that we will look forward to your feedback of these sessions. We bring them to you monthly, the last Wednesday of the month. And so if you aim your camera on the QR code, we'll look forward to gaining feedback from you. And you'll see this a couple times throughout the presentation, but want to make sure that you have the opportunity to provide some feedback back to us. So we'll go to the next slide here and talk about our two speakers this evening. So Dr. Matt Aboudara is at St. Luke's Medical Center in Kansas City. I think he's been there for just about a year, came from Vanderbilt prior to that in the Interventional Pulmonology Fellowship Program, and really worked a lot with that group, and looking forward to him sharing some of his experience with Illumicite as he just received this within the last couple of months. And Dr. William Hall, pulmonologist from Rex Medical Center in Raleigh, North Carolina, where he has been for the last almost 10 years. Lots of experience with our technology. Both of these gentlemen are a part of what we call our centers of excellence. They are providing training and education for physicians who are interested in working with Medtronic, and with them to partner on the opportunity to learn more about the Illumicite technology. So if interested, make sure you let us know. And without further ado, I'm going to pass the ball over to you, Dr. Abadara, and we'll let you get started. Thank you so much.
Okay, thank you very much. Thank you everyone for being here tonight to listen to us talk about the Illumicite platform and our experiences with it. We'll skip right over this. We'll jump right in. So these are some things I'm going to highlight and talk about here this evening. I'm going to give a little bit of background on some of the limitations for currently with navigational bronchoscopy. I think that'd be helpful as we look at how digital tomosynthesis and the Illumicite platform help us to try to correct for those deficiencies. And then go into digital tomosynthesis, Illumicite, and then certainly go over some cases and go from there. So very high level overview, and not to spend too much time, but in general, we all know that the diagnostic yield has plateaued, and somewhat frustratingly so. A large meta-analysis back in 2014, over 1,000 nodules with a median size of about 2.5 centimeters, demonstrated diagnostic yield of about 65%. This systematic review was mainly done with all except one study done with superdimension platform. Recent large, well-known, discussed prospective cohort study, the Navigate trial, over 1,000 subjects, median size of the nodule about 2 centimeters, 50% with a bronchosine with a diagnostic yield about 73%. And then a recent retrospective study looking at pre and post introduction of fluoroscopic navigation, about 101 nodules, about 1.5 centimeters in size, third with a bronchosine, and a 55% diagnostic yield with standard EMB. So obviously it's plateaued. I mean, generally depending upon the size and what diagnostic yield criteria you're using, probably anywhere from maybe high 60s to 70% in terms of our yield. About 40% of nodules are going to be invisible under fluoroscopy during bronchoscopy, which certainly can make it more challenging to localize these effectively. And certainly, while we've known about it for several years, certainly it's been talked about more frequently lately, is the diagnostic drop-off sign. We can get to these nodules in an over 90% localization success rate, but our diagnostic yield drops to maybe about 30 to 40% of that. And so why is that? Certainly, are we actually biopsying the nodule is one realistic consideration. Concept of CD body divergence, which is the difference in the location of your nodule based upon your pre-procedure CT scan from its actual location during the procedure itself, has come significantly more to the forefront over the last 1 to 2 years or so. All navigational bronchoscopy platforms, any kind of advanced diagnostic bronchoscopy platforms, are going to be based upon a pre-procedure CT scan. So anything like atelectasis, anesthesia, paralysis, scope wedging, blood clots, etc., are going to affect your position substantially in terms of where that nodule is going to be at, and respiratory variation is certainly going to play a role as well. Certainly, we probably have all been biopsying false positive radio ultrasound images and counting that as successful navigation. A recent nice study by Sagar and colleagues demonstrated that these are actual radio ultrasound images of atelectasis, and they certainly look like lesions to a lot of people, and that's probably more often than not what we potentially have been biopsying. Atelectasis develops very frequently, lower lobes predominantly, obviously, makes intuitive sense, but certainly the upper lobes can occur anywhere from 15 to 20%. And certainly relation to the biopsy tool as well is once we know where it is our biopsy tool actually going into the target lesion, or is it going adjacent? Are we missing it? Is it going too far? Where exactly is that in relation to our nodule? So digital tomosynthesis is, just to give a brief overview on that, this is your C-arm that we would be using in GE 9800 and 9900, and then the patient's going to be in the center of this. This is done during an inspiratory breath hold that you work with your anesthesiologist to help maintain that. And you rotate during that breath hold from 25 degrees left lateral oblique to 25 degrees right lateral oblique over 15 to 20 seconds. It can be in the opposite direction as well. These images are then flattened out to allow catheter and nodule identification, and then your nodule and your position is updated relative to your catheter. You finally get to use this button, this fluoro foot pedal that has that plus sign next to it, the high intensity fluoro button that you've been avoiding all these years. So Illumicite now, in addition to once you've updated the position of your nodule with digital tomosynthesis, and you know where your nodule is located now during your procedure as related beforehand, the Illumicite platform now allows for continuous sampling of your nodule while you are continuous on-time sampling of this. So this is a sampling of a procedure I'll discuss in a little bit. This is the needle. The LG is out of the working channel, so there's fibers with censoring fibers within the extended working channel that allow continuous sampling of the nodule. So a very fantastic feature to this platform. Okay, so what about the data for digital tomosynthesis? And there obviously isn't a lot. It's been fairly new out on the market. The main point that I want to highlight from this particular study, what these authors did is they used cone beam CT as essentially their gold standard in terms of confirming is the navigation, is your LG and your extended working channel actually at the target nodule where you would feel confident in order to take a biopsy specimen. So they navigated out, they did a cone beam CT, and they measured the degree of overlap or lack of overlap, and did your digital tomosynthesis, corrected for that, and then did another cone beam CT to see what the difference was. And so if you just use standard navigation with this and you compare it with the cone beam CT, you're about 68%, which provocatively is somewhat close to our diagnostic yields that we're getting. Then if you correct it for digital tomosynthesis, you have about a 95% overlap with cone beam CT. So I think the take away from this is if you can you actually trust your updated green ball that you have? And I would say yes, you can trust it with a high degree of confidence, as I'll show you in in a couple of cases. So finally, some data, a study I was a part of, and looking at digital tomosynthesis. This is a pre and post, looking at mainly patient characteristics and diagnostic yield after the introduction of digital tomosynthesis. And some main key points I want to highlight is that, number one, the bronchus sign in both of these cohorts, particularly the fluoroscopic navigation, was only 15 of the 67 nodules that were biopsied had a bronchus sign. So, and majority of these nodules were around 1.6 centimeters in size. So over 60% were less than 2 centimeters in size. So very small, difficult to reach nodules. And with this, a diagnostic yield increased substantially by 25%. Obviously, retrospective study and certainly limitations to this. So that's why there's current impetus to go on to investigate this further. This is a multi-center randomized control non-inferiority trial that's currently enrolling, comparing navigational bronchoscopy with digital tomosynthesis versus transthoracic needle aspiration, with the primary outcome of diagnostic yield. So a very exciting study, and certainly going to look forward to those results in the hopefully near future. All right, so with that, I'm going to jump into a couple of cases here, and we'll go on from there. So I have 3 cases here to talk about. So the first case is, this is an enlarging right middle lobe nodule in a smoker with emphysema. She was not a good surgical candidate due to her comorbidities and her underlying lung function. You can see on the left CT scan was her one of her CT scans done approximately 6 months prior. Very small right middle lobe, lateral segment. No, these were thin cut slices, no obvious airway going to this nodule. This nodule around here was about, I think, 5 or so millimeters in size. And 6 months later, the nodule has increased in size, and so she was referred for a diagnostic procedure. So I'm going to walk through this. This is the first video I have, and this is the only time I'm going to show the video of going through the screen just to show some familiarity with it. It's very similar, almost identical to what's currently for this. This is after registration is being completed. And then you verify your registration accuracy from here, and then go right out to the right middle lobe nodule. So we're getting out there, and then pull up for a target alignment. So I'm just going to pause there. What I'm doing here is that I use a scope holder. So my respiratory therapists that help me out are tightening down the scope holder, or getting it locked in for me. Now, typically how I may approach this is I may take out the LG and then use a radial ultrasound probe. I'm right on top of it. I could easily do that and not use and if I see a concentric view, then just go ahead and take my samples there. For these cases, I should have mentioned a little right before this, is that for all 3 of these cases, my radial ultrasound probe was not functioning up to par. And so I really couldn't rely upon it at all. So I was depending heavily upon the digital tomosynthesis for this. So that's what I ended up doing. So once this is done, once you're here, then this is your initial image capture for this, right before you're getting ready to do your digital tomosynthesis sweep. So this image is captured. I'm communicating with the anesthesiologist that we're going to go ahead and set our APL valve at a certain value, and then we're going to suspend respirations. The C-arm is rotated over to left lateral oblique, and then we start the breath hold maneuver with the fluoro sweep maneuver with the high intensity fluoro, and go over to the right lateral oblique for to 25 degrees. We then complete that. The patient goes ahead and breathe, and then we update the distal tip of the catheter. These are in different planes, so the catheter tip is marked and updated. And then the nodule. This obviously is a sub-centimeter nodule. What it was between 7 and 8 millimeters, around 8 millimeters in size. So, so that's your updated. It was right on top of it. And these are the biopsies with the needle. So I used the 21 gauge arc point needle for this. And this is the Illumicite addition to this, which is pretty cool in my mind. So I just want to back up for a second there and show a little about this. When I started with this, you can see I was off to the side when I was biopsying this when the needle was out. So what I did was I just pulled back the catheter just slightly, and then I was able to get directly right dead center into the nodule, being able to take some samples of that. I think when you're biopsying these, particularly with the Illumicite, if you use edge catheter a lot in the past, you're going to see differences with this. This catheter is going to hold its stiffness. And so a stiff tool is going to play a little bit more into your advantage with this. This arc point landed me directly right where I needed it. And so I didn't have to worry too much more about in terms of a stiffness related to that. But that is one particular feature about Illumicite and these catheters, and one thing to try to work on your alignment. Here, that helped me by just pulling back and helping me get directly within the center. So this just shows, this is the agitation of the needle right in the center. I think particularly for these small nodules, this is a sub-centimeter nodule going after this, having this feature is particularly important. It's nice having the fluoroscopy view on the left side to be able to have that real-time fluoro. I thought maybe if I zoomed up, I thought maybe I could see it. Maybe I couldn't be overly confident though. So, but it's nice to have that feature that's there. I'm working to go to the next slide here. And so that was adenocarcinoma papillary predominant. Okay, so the second case here was an elderly man with, again, multiple comorbidities, not a great surgical candidate. He was emphysema, former smoker. And so he had this nodule. This was actually, there was a component, almost looked a little dumbbell shaped, and there's a component, I think, of atelectasis associated with this as well, as you can see. And so this was where it was located. And I'm not going to go through with videos on this, but this is my navigation initially right out to it. You can see I'm right on top of it. Now, if I pulled LG out of this, I'd probably be about roughly a centimeter away from it. Maybe a slightly little bit too close to it right now, but I'm right on top of it. And so you could potentially feel pretty confident with that throughout your radio ultrasound probe, and or just take some samples based upon using that in your fluoro. You can see it under fluoro. So this is the, I skipped over the updating on catheter position. This is your nodule target plan. You can see this is the component right here that I was targeting. I wasn't confident this was entirely lesion. It may have been some component of atelectasis. So I was looking to target this area up here. You can see it very well. And then this was after correction. So off target for my nodule. So this is the CD body divergence. I would say, you know, I've done probably with the just with the FluoroNav, not with the Illumicite. I don't know, probably did around 150 some odd, a little bit more than that, just with FluoroNav. And I think the navigational accuracy is better, as well as the seems like to me that the image sharpness with the nodules is also a lot sharper as well. So this was divergent, CD body divergence. And I then just pulled back the catheter, you know, did some manipulations and was in line with that. And then again, I didn't have my radio ultrasound probe available to me, so I just used that, and I used my target alignment, and I went ahead and made my biopsy. So I showed this video already of sampling it. So this is the Illumicite component to this with the target alignment feature. And this is invasive moderately differentiated adenocarcinoma. All right, so this is the last case I have. These were interesting case in terms of approaching it, as well as these were small nodules, and talking about maybe some different tools to use. This is a 70-year-old female. She had a history of breast cancer diagnosed several years ago. It was local breast cancer. She had multiple pulmonary nodules identified on imaging. She actually had an IR declined to do a CT guided biopsy. She actually had a couple of other nodules in the right upper lobe that was medial, the lower lobes that were also based. And so we were asked, I was asked to go ahead and perform a bronchoscopy. So this nodule here on the left, there's a bronchosign that is tracking to it in the left upper lobe. And this nodule on the right, in the anterior segment of the right lower lobe, this actually was bifurcating between two airways. So my approach to this was, I think you could take a small thin bronchoscope, go out with a radial probe, and try to find it and take a sample of that. My feeling was, though, is if I went after that, and if I got a diagnosis other than breast cancer, because that was high up on my differential, but then I wanted to go to a second nodule. And that's why I planned for the second nodule based upon where the other ones were. I felt this is the next best target that I had. And so I didn't want to delay time in terms of if I used another tool, then to go back and to put the sensors on and go and register the airways while atelectasis is developing. I basically just wanted to use one tool to do the procedure. Plus, I didn't have a radio ultrasound probe available to me, so it wasn't functioning well enough for me to be confident about it. So I went ahead and used this. So this is about 6 millimeters in size. This nodule here is about 6.7 millimeters in size. So these are the images that I have available for this. This is the left upper lobe nodule. Obviously, you can see it very well after the digital tomosynthesis that I used to localize the nodule. The target is updated and marked, and this again is a target alignment with the crosshairs right in the center of the nodule. So when I got back on that, I didn't get back something suggestive of breast cancer. So I went after the second nodule in that left lower lobe one. And this is where I thought that using a more stiffer tool, it's where I used a brush, which I usually don't use as much because it's a little more stiff and it usually deflected me more when I was using edge catheters. So I didn't use it as frequently as maybe some other people would like to use. And so I used that then, and that actually, stiffness of that actually helped me more so to get in line with the nodule. But regardless of that, we ended up getting typical carcinoid from both the left upper and the left lower lobes. I was able to get both with the brush and with the arc point needle and with the biopsy forceps on that too that I used. So those are the cases that I have. Obviously, Illumicite allows for correction of CT body divergence. You can identify small nodules exceptionally well. The ability to identify them is fantastic. I'm certainly not advocating to go after sub-centimeter nodules routinely, but I hope that I showed in some of these cases, sometimes you have to, and you can definitely see them and locate them. You're able to biopsy these lesions continuously. In some cases, you probably don't need radio ultrasound. I'm not saying you don't need it all the time. I still use it when I have it available and it's working. But obviously in these three, I didn't need it. And I would say absence of bronchus sign shouldn't limit our ability to biopsy these nodules. Many of these, I think 3 out of 4 of these didn't have an obvious bronchus sign on that. So if you see the nodule and you put a sharp tool directly into that nodule, you create yourself a little airway. So that is all that I have, and I will go ahead and turn it back over to my colleague.
Thank you, Dr. Abadara. This is Jody. There's been a couple of questions that I thought maybe we'll just pause for a second here before we jump into Dr. Hall's presentation and ask you a few questions, and then we'll also have time at the end. So feel free to enter your questions into the chat or question box on your Zoom interface. One question we had from the audience was, do you see your yield improving from your Vanderbilt data that you shared with Illumicite?
So right now, I'm pretty early into it right now. I think that's, I think we've done probably about 20 cases with that. So, but I would say yes. I mean, I would say yes, that the yield is going to be improving. I mean, we're referred some difficult nodules, these small ones, these nodules to get after. I think the yield definitely will increase with this, especially when you're able to see where your biopsy tool is going to.
Okay, perfect. And then the other question was, so in the past in using 7.2 till your experience now with Illumicite, what kind of differences have you seen, and how has this sort of changed the way you're perhaps approaching your patients?
Yeah, I think I was very confident with 7.2 and very confident with this in terms of going after nodules. You can see them very well. There are some differences with the Illumicite platform, and particularly the catheters. The catheters are different, so it does take some adjustment to get used to that in terms of how they feel. They hold their stiffness more, and so I used to do a lot more. If I would go out and let's say I would go out to a nodule with 7.2, it was a small nodule, and we would do the sweep, and then I would, but we couldn't get a concentric radial ultrasound view. We would then fight for that concentric radial ultrasound view now that we knew where the nodule was. And we'd fish for it. You know, you'd go out with your edge catheter, you throw out your radial probe like a snake's tongue, and try to find the nodule, and then get centered up on it and get alignment to this. With this, I don't do that. I don't think with these catheters, that's a little bit of that's a difference, is that I trust my, I'll still use my radial ultrasound probe, but I'm not going to keep my radial ultrasound probe in and then manipulate the catheter to try to get a concentric view and get up on alignment. I like to try to see it if I can, whether it's an eccentric view, but then but the tool then it myself that I'm passing my tool then through will allow me then to get my alignment, and then I can adjust my catheter with the tool in place. I think I can trust that green ball essentially, as well as in a lot of cases as having my radial ultrasound probe. Hopefully that answers a little bit the question. There is a question about have I used CrossCountry tool? No, I don't use that for an eccentric radial ultrasound EBUS image. I think for this, I think if you're able to, I think the key with this is trying to get the alignment that you best can get on with your tool in the EWC, and trying to get that alignment up as best as you can to be able to do that. Sometimes what I've done is use larger forceps than the Medtronic forceps. I use standard forceps, and to try to grab a larger piece or to extend out farther to get the nodule if I need to. Am I able to use the arc point as it's more flexible? Yes. All the cases that I used that I showed right here were all the arc point needle that I used.
Wonderful. Thank you so much. Appreciate your comments and experience, Dr. Abadara. I know we're going to switch to Dr. Hall, and then we'll come back to questions again here at the end. Go ahead, Dr. Hall.
Okay. Can y'all hear me okay?
We can.
Great. Okay. So I'm happy to be here. I'm a pulmonary critical care doc and not an interventional pulmonologist, but I have done quite a bit of navigational bronchoscopy over the years and used various platforms. So this is a community pulmonologist take and experience on the new platform compared to prior platforms. Hold on. Oops. Okay. So first case I have for you is a 64-year-old gentleman with about a 50-pack year history of smoking, and essentially had an incidental nodule found on a CT angiogram when he had acute onset shortness of breath. It was found to have a pulmonary embolism at that time. He was referred to me after he had received anticoagulation for the PE, and he and I had a lengthy discussion about what to do about this 1.2 centimeter nodule in the superior segment of the left lower lobe, kind of tucked in right next to the aorta. I had some other images, which unfortunately I don't think they were able to import some videos, but at that point we elected to give him some anticoagulation and follow up on the CT, and then sure enough the nodule didn't change. But in the real world, you're left with a gentleman with a 1.2 centimeter nodule, new recent diagnosis of a PE, and some decision about what to do. So we decided to biopsy it. And the nodule is there identified, as you can see on the planning. One thing I'll just pause and show you. Some of you have you've done navigation before, and I've done this planning so many times, and I can say that so many times in earlier times I would have a difficult time with some of the planning, but the planning in the newer platform has been so much more straightforward. Inevitably, and this view is particularly nice. I'm more fond of this view to show me where my scope was going relative to the registered or the presumed airways from the software. And then in this case, I wish I had the CT images to show you, but we've all probably seen these. So imagine a superior segment, 1.2 centimeter nodule tucked in posteriorly and like right up next to the aorta. So in the old system, I would have been a little worried about doing a navigational bronchoscopy on this out of fear of hitting some surrounding structures, either the pleura or the aorta. In this case, and of course my radial EVIS wasn't working that day either. That thing is fickle, and it seems like it's broken more often than it works. Well, no, my radial actually was working in this case. The next one it wasn't, but regardless, got to the nodule and wanted to know when we pulled out the LG, where was I deflected? And so, and there also wasn't an airway going to this nodule, I'd have to add. But in the real world, it seemed to be looking pretty good. And this just shows where you bring over the fluoroscope and make sure that you're in the surrounding parenchyma and do the sweep. I'll have to say that if you've done, in doing the sweep, if you haven't had to do this before, it's pretty straightforward, but it does take a little bit of coordination in the entire endosweep. And it's good, actually. So you're very much interacting with your anesthesia team. You're getting the breath hold. Then you're, I'm often talking to the fluoro team beforehand, making sure that you know they know what they're doing. And it gets pretty fast and pretty efficient pretty quickly. In this case, we did the sweep, and you can see the target. You can see the target right there is pretty well identified. Yeah, and you can see I confirmed with radial, so the radial did work today, and it was on a central location, and everything went very well. I didn't get too close to the aorta and didn't cause pneumothorax. And then the diagnosis was confirmed. In this case, it was adenocarcinoma. He had a subsequent PET after tissue diagnosis and is being sent to thoracic surgery for resection. This was the only thing that was FDG avid. And actually, the FDG uptake was minimal, and so we would have elected probably to follow this, although it was tissue proven. So I think that really helped us to move ahead and do a biopsy. This next case is kind of similar to some of yours, Dr. Abadara. This was a lady who I'd seen. She had been in and out of our pulmonary clinic for a while. She had clear cell renal cell cancer in 2012, resection at that time. We had seen her for cough and some episodes of pneumonia. She had had some abdominal CTs back in 2017, 2018, showing some very small pulmonary nodules. They were then followed up with us. And one of these cases that over the years, she's accumulated a couple of CTs, and you start to look back at them. And, well, look, these nodules are there. And when you really line them all up, even though some of these CT scans have been separated by 6 to 12 months, some of these nodules were a little bit newer than some of the old ones. None of them are going away. And in hindsight, there's several that are getting bigger. She and I had a heart-to-heart here in the middle of the pandemic about this and discussed our options. We could resect a nodule. We could continue to watch them. But as I tell people, if you keep doing what you did, you'll get what you got. And in this case, she said, well, let's try a so-called non-invasive biopsy or a less invasive biopsy, one that doesn't have me getting a surgery necessarily. And I said, now these are small. The biggest ones were one in the upper part of the right lung that was 7 millimeters, and one in the right middle that was 6 millimeters in size. And but the beauty of, I think, the NavBronch for me is the ability to identify several targets, and right then and there, walk through each one and try to assess several things at once. So this shows the initial assessment of the right upper lobe nodule. This was 7 millimeters by 5 millimeters. Obviously, you can't see it on the initial fluoro imaging, which is normally the case. But then after you do the sweep, it's fairly clearly identified. Now, in this case, the preliminary path on this right upper lobe nodule was non-diagnostic. So I went on to the right middle lobe nodule. Now this is a small lateral segment right middle lobe nodule. It was, I think, 5 by 6 millimeters in size. And on this one, it's identified. You can see it right there. Now, I had already spent some time in the right upper lobe. I think this entire case took about 45 minutes or so, but I already spent some time in the right upper. And so now I'm going down to the right middle, which would be apt to some atelectasis anyway. So the initial navigation had me quite close to the nodule, or so I presumed. And the nodule, as you can see there, is quite small. Yep, hold on. Let me go back one more. I didn't know if I had another skin. When I did the sweep and we dialed in on the target, I was 2 centimeters away, which meant that I was in the wrong airway. I was pointing at the green dot, thought that I was where I needed to be. But after the sweep, I was nearly 2 centimeters away. Turns out I was in an adjacent airway. I felt like the right middle lobe can be really tricky that way. Small, you think you're going to be right where you want to be, but then you're not. So after the sweep, re-navigated and got a diagnosis of metastatic renal cell on a 6 millimeter nodule. And so basically what that tells me is, and I've used these platforms for a while, and at times you can be aiming at something and feeling quite confident about it based on an airway sign or something else, fluoro confirmation or radial or what have you. But at times it's as if for almost any navigation that you can get to your target, but your target's off. And I think this has given me a lot more confidence to, when it's appropriate, to go after the smaller nodules, nodules that might be in some ways riskier or more or less straightforward. I think the catheters are a bit more rigid, so I used to go to the medial probe a lot, and these days I'm using a lot more 90 and 180, and I'm not as worried that my radial's broken, which is as often as not. And that's it. That's been my experience out here in the community.
Wonderful. Thank you so much. I really appreciate the insights. And I know we have a couple of questions here for you as well. So Dr. Hall, I'll ask you, maybe how has continuous guidance been impactful beyond just using fluoroscopic navigation technology?
The continuous guidance. I mean, the continuous guidance is wonderful because inevitably you think you know when you pull out the LG where you're going to deflect, or then when you insert some sort of tool where you're going to redeflect. But inevitably it does something a little different than you might have intuitively thought. And that's understandable. You're in, a living, moving structure. And so I think the continuous guidance has increased or shortened my time of a procedure, increased yield quite a bit. Particularly nice if if you're in the middle of a procedure and you know that you're on a good target based on the sweep, and then you can see how the target looks with the LGN versus without. Then you can kind of keep that mental map in your head, and then as you deploy various, whatever you're going to do, a brush or a needle or a biopsy or whatever, if you knew you were on it, then you also know you're on it. So I end up using the LG early and then no more. So that ends up working quite well.
Okay, great. Another question is, compared to the use of robotics, what benefits does Illumicite offer in your experience? I don't know if either of you have used robotics in your institutions or anywhere else, but any insight on that question?
I've not used robotics.
Yeah, I've not used robotics either. I mean, I've seen some in action. I think, you know, I think one aspect of that is certainly is the CT body divergence correction. To be able to do that, I think is extremely important, and that was important for us in terms of considering various different platforms. To know confidently where you are is obviously critical to know. And I think now with the Illumicite, you know, both the robotic platforms and Illumicite have the real on-time, you know, actual biopsy of the nodule than the other platforms. So I think having the CT body divergence correction is very important, in my opinion.
To me, I think you're only as accurate as your navigation. If I give you if we had a gun with bad sights, then we're going to miss the target. And as far as I'm concerned, as long as the navigation is accurate, then and you get comfortable with the accuracy, then that gives you some confidence to know what you're able to do and not do. And so I can speak to my experience with Illumicite, but don't know about the accuracy of the other ones.
Okay, great. Next question is, with the Illumicite platform and now your experience targeting nodules without radial EBUS due to downtime, do you think radial EBUS is still essential?
I would say that old habits are really hard to break, especially when you've leaned on radial ultrasound for so long for confirmatory, to make sure that you're at and you can actually trust the machine. I think right now I'm going to continue to use it, and until I'll continue to use it for right now until as I grow more and more comfortable with trusting where that green ball is at. It's just hard to let go of that, you know, when you've been using it for so long. But I do think that you can get to a point where you may not need it very much at all, and you have the confidence where you're going in, where you know you're actually targeting that. I think one aspect that I do think radial ultrasound will be helpful is determining your the end of your nodule, or where you want to target. How far can you extend your biopsy tools out? If you're able to mark that in, or you have a mental image about where that's at, then I think it could be useful then. But, you know, and I do anticipate that we may not have to rely upon it as much potentially. That's my thoughts.
I mean, I think we're forced at times to work without it, and that gets you more confident in working without it. And I'm not that worried when it's unavailable, either being cleaned or broken or both.
So other question for you, Dr. Abadara, I know you mentioned you use a scope holder. Is there any additional information that would be helpful to share with the audience in regards to that tool?
Yeah, so we use what we did, we sort of cannibalized a Draeger ventilator tubing holder that you'd use for your ventilators in your ICU. We just grab that and attach that to you have to get extra pieces that will then be able to latch onto the bed. And so that's what we did to try to save some money, is to use that and then get that to hold onto the scope. I will say we have both Fuji bronchoscopes and Olympus bronchoscope, and it doesn't hold very well with an Olympus scope, but it holds reasonably well with a Fuji scope. But there are other bronchoscope holders that are out there that hold them really well, and I loved it. I mean, I think it's awesome. It changed my life. So it's fantastic to have that. That way you're free. You can sort of back away. You can go get a latte or go talk to the cytotechnologist, whatever you want to do, and you can back away from the fluoroscopy too by doing that. So.
Okay, there's another question from the audience around using CT, cone beam CT versus the C-arm for the sweep. It says here, given the C-arm spin required for Illumicite, could a cone beam CT be used for the same tomosynthesis instead? That way you'd be avoiding swapping a C-arm for cone beam CT.
So in terms of equivalence with digital tomosynthesis versus cone beam CT, I think it's probably about, that was based, that study that I went briefly over was about 95% accurate with cone beam CT. It was pretty accurate with that. The nodules in that study were about median size of about 1.5 centimeters in size. So in terms of using cone beam CT instead, yes, you could. That could be a way that you could correct for CT body divergence. You could do that. For us here, for where I'm at, it's just a matter of being able to get cone beam CT guidance, being able to use that consistently and for all cases. It's just not practical for us to do that in terms of the time it would take to do that, the number of cases we want to do in a day, and so forth. So you could make that. That could be a potential. I know there are some somewhat more mobile, cone beam CT type devices, but then you're factoring in costs related to that. So that's why for the vast majority of cases, using almost all of them, using the digital tomosynthesis is giving us enough confidence where we don't need a cone beam consistently to be able to do that for the vast majority of nodules that we're going after.
Yeah, we don't have a cone beam, so we looked into it, but it was going to be expensive and cumbersome, and we wanted one thing that we could use consistently and reliably, and it wasn't going to break the bank.
Yeah, just carrying on that question, for those who haven't maybe used Illumicite and don't know much about the FluoroNav feature, certainly you guys have talked to the favorability of the images. Is there anything worthy of sharing just around how that works, or the ease of use, and getting used to it, and how you utilize that best, and how you most learned how to work through the workflow pretty quickly?
You want to go first?
Sure. I've used this product for a while, and if you've used it before, the change is not that great at all. There's 2 wires instead of 1. The catheters are 90 and 180 and a little bit stiffer. The one thing that is different, actually, I think strengthened from my side, strengthened our endo unit in some ways, was kind of put you in this moment where we always talked beforehand, but just tell everybody, hey, make sure you're talking to your anesthesiologist a bit more, making sure they know ahead of time what we're planning on doing, the fluoroscopist too. And once you've done that a couple of times, the prep and then the sweep, then that part is fine. I actually thought it would make the cases take longer, but it makes the whole case actually shorter, because you get yourself to the green ball, then you dial in the green ball. That's the part that takes longer because you didn't have to do that before. But then once you're there, between the continuous guidance and the confidence that you're pretty much on it, then you're not constantly putting the LG in and renavigating and looking again with fluoro and wondering and waiting and speculating. You're just kind of there, and then you can kind of sample around, but you already know you're pretty much on it. So I think it takes a couple of cases if you know what you're doing from before, if you've done it before. And then overall, after a few cases, it feels just as fast, if not faster, and way more accurate.
Yeah, I would.
Perfect.
Yeah, I agree. I think that one of the first cases I did with one of the respiratory therapists that helps me out was like, wow, that was a lot quicker than what we did before. You know, I came here and was using 7.0, was pulling my hair out, trying to find these nodules, and then we, you know, did this case, went out, did the suite, corrected for it, got the, you know, knew where we were, got samples, got a call, and we were done. And that was her response was, wow, that's great. It's a lot shorter than what it was before. So once you get used to the workflow on that, our anesthesiologists are very easy to work with, and just the nature of our group. So it wasn't to say what we were going to do. Say, hey guys, we're going to do this breath hold for about 20 seconds in the case, and we're going to just talk a little bit about what that's like, and that's really it. And they were fine with it. It's no big deal for them. It was a small little additional thing to do. It wasn't that too much of a transition at all for the anesthesiologist. They didn't really even blink. And then getting the staff used to it and the workflow, you know, that takes a little bit, but that's, I think, part of anything that you're doing in terms of introducing some kind of new step to the technology, but it's been pretty seamless.
Okay, so 2 more questions. And if you've got any from the audience, feel free to type them in. I know you both talked a little bit throughout your presentations about sort of tool selection and maybe catheter shape and curve and some of the differences. Any further information that would be helpful to share with others as you've kind of gone through that thought process and the difference from your previous superdimension experience to now Illumicite? Dr. Hall, I think you
go ahead.
Yeah, go
ahead,
Doctor.
You go ahead. Go ahead.
Okay. All right. I would just, one thing to think about is the stiffness. I think for me, it's been making adjustment. I downgrade my catheter. So if I'm going to use typically going to use a 180 catheter for a case, I'm looking at using a 90 for the Illumicite. I don't use the 45 as much. I think the one that I showed with the bronchosine, the small nodule, I used the 45 on that, but pretty much all the others were a 90 that I used, 90 degree on this. And so I think the 180 for the Illumicite is going to be stiffer than that. So that's one from a catheter selection standpoint that I would consider with this. That's all I got.
Yeah, I think that's about it. I think you know, I tend to use a lot of 90 for things in the lower, and then if I'm trying to really hook around, I'll use the 180. The 180 tends to get you in, you know, through some tight spaces, and that's about it. I think really it's just down to the navigation piece and whether it's, you know, whether you feel comfortable where you're going or question whether you really got there. And in the newer system, I just feel like in general, I've been able to get where I wanted to go.
Yeah,
okay, good deal.
One thing about that radio probe, just to comment about that, and is that because the radio probe's a little bit more, it's obviously not as stiff as your biopsy tools. So if the catheter's bent and then you put your radio ultrasound probe through that, and you're trying to fight for a nodule position with that when you're not straightened out with your biopsy tool in place, it's a little bit harder to get it's different to get it than if you're using an edge catheter previously. If that was your practice, if that's what you did. was you had your edge catheter, you got out to the nodule, and then you put out your radial probe when you were close to it, say within a centimeter, and you try to do it, you throw out your radial probe and maybe move your catheter around to try to do that. With this, I'm backing away from doing that quite a lot, and so I'm not doing that as much. Because it's just flimsy. The catheter is holding its curve more when I'm putting the radial ultrasound probe, so I can't do that as much anymore. But if I put a biopsy tool in it, it sort of straightens it out, and then I can maneuver and stay on target about where I want to go. It just requires me to trust that green ball from the updated position.
Okay, one other question the audience just came up with. Are you doing your procedures under general anesthesia?
Yes.
Yes.
Yep, okay. And last question I'll ask here, and we'll close out as we're at the top of the hour, and I really appreciate both of you sharing your experience. If you had to say the biggest difference from your previous superdimension system to Illumicite, what would you say it is?
I would say that I'd say a couple things. I'd say probably the navigation is more accurate. I think the navigation is more accurate going out to it. I would say the ability to have real-time biopsy of your tools, I think, is of your tools going out into the nodule is a huge plus to be able to have that. To see if you're deflecting, if you are deflecting, how can you correct it to direct it in? I think those are huge added pluses for this. And I personally think it seems like it's sharper too in picking up the nodules as well.
For me, I think confidence and speed. At times you'd be asked, and we all get these CT scans with these abnormalities, and no one makes these things up. So you get this scan, and I wish that nodule were somewhere else, but that it is what it is. And so I think some confidence to go after things that are more challenging, and then whether you get an answer or not, feeling a lot more comfortable about your result. And I think also speed. I think being able to do things a bit more quickly overall. And the always on catheter is definitely made me feel a lot better about from pass to pass, if the patient coughs or hiccups or whatever, knowing that we're still where we were instead of having to kind of re-guess where we are, and to stay focused on the target.
Well, that's a great way to close out the session here today. Really appreciate your insights, appreciate you answering our questions and sharing your experience. We hope you as the audience was able to get a good glimpse into the Illumicite platform and the different features and benefits that it will offer you. And so we look forward to working with you. We look forward to seeing you next month on our next Wednesday webinar. And a really special thanks to Dr. Hall and Dr. Abadara for sharing this evening. Everybody have a nice night and stay safe and healthy. Thanks again.